Hello, everybody. Welcome back. Welcome to our series of podcasts that we call Menninger Mindscape. I'm Dr. John Oldham, Chief of Staff at the Menninger Clinic, and we're delighted to have as our guest today Dr. Marie Dewitt. Marie, welcome.
Thank you.
Dr. Dewitt is a staff psychiatrist in the mental health care line at the Michael E. DeBakey Veterans Administration Center here in Houston and is on our faculty in the psychiatry department at Baylor. But not for long, because she unfortunately, to our regret, but I think a wonderful move for her, is going to be relocating soon to Detroit, where you're going to be, I want to get it right, Director of Acute Psychiatric Services, and also on the faculty at Wayne State.
That's correct.
So it sounds like a wonderful opportunity for you. Lucky for us, Marie has agreed to come back for our fall symposium co-sponsored by the Department of Psychiatry at Baylor and the Menninger Clinic. And that's going to be on the theme of impairments in cognition. Marie is going to be one of our speakers and is be talking about, our official title is Delirium Acute Brain Injury. So we never have but a little bit of time to hit some of the highlights, and we'll hear more about it at the actual presentation. But start us out with telling us what you think about when you use the word delirium.
So delirium is I find very interesting, obviously. It is a condition that affects the brain. It's often, as I explain it in kind of lay terms, when the body is sick, the mind gets sick sometimes too as a result. And delirium is a condition where attention is impaired in the brain. And so people's ability to focus, to pay attention consistently, and to switch their focus of attention becomes impaired. And it has a rather abrupt onset, sometimes over a course of a few hours to several days. It's a change from the person's underlying behavior. And it often fluctuates, which is confusing. So family members or hospital staff will know that something's off, but they won't quite know what's going on. So delirium is really a state of confusion.
Well, it's interesting you use the word condition. Mm-hmm. So would it be fair to say that an analogy might be something like fever, in that it could be caused by a whole series of different things, but it's got a recognizable sort of profile?
I think that's a fair analogy to some extent, at least. Delirium is both a diagnosis as well as a symptom of something underlying it. It can be either due to pathology or some kind of process going on in the brain, or some kind of pathology or process going on in the rest of the body, not the brain. So sometimes I'll use the analogy exactly of a fever or chest pain. Mm-hmm. Chest pain can have a lot of different causes. It's not always a heart attack, but that's always the fear.
Yeah. So at our conference, another thing we're going to be talking about is dementia. Mm-hmm. So how do those words differ?
So it's interesting, even when I was in medical school, which wasn't that long ago, but it has been a few years, we were taught that delirium was completely reversible, that someone would get sick, become delirious, and then once that resolved, they'd return back to their pre-morbid or pre-delirious state without any deficits.
And I went to medical school way before you did, and I was taught that too.
Yeah. So just since then, though, what the literature and research is showing is that delirium isn't always completely reversible. And in fact, in a lot of cases, people continue to have some deficits after they're delirious. So I bring this up because the line between delirium and dementia is getting a little bit blurred nowadays. Mm-hmm. Dementia, though, by definition, is a chronic neurodegenerative condition, meaning that things get worse over time. And a lot of times with dementia, there's actual cell death going on. And that process occurs over years. Delirium is more short-lived in general, and people do generally improve as the course of delirium starts to resolve. But we're finding more and more that there may be some more permanent deficits from delirium that may worsen underlying dementia that someone may already have, or may predispose them to developing dementia in the future. Yeah. So it's a great question. We used to describe them as completely separate entities, and now those of us in the field see it as more on a spectrum.
Yeah. A lot of medicine is, I think, coming around to recognizing the dimensional nature and the somewhat artificial categorical system that we've used.
Absolutely.
Where we say you have this disease or you have that disease, and they're totally different. It's not so black and white.
It's
all the
not.
time.
It's one of my pet peeves that we try to dichotomize things,
Yeah.
actually, in medicine. Yeah.
I mean, I keep using analogies in my head as I'm listening to you, but like infection seems to me sort of like what you're talking about. We think of it as something that has its onset. We identify the organism, we pick the medication, we treat that, and it goes away. But it doesn't always go away.
It's true.
And sometimes it can be long-term and a whole range of shades in between.
That's true. That's very true.
But you mentioned when we were chatting earlier that there are sort of subtypes. So say a little bit about that.
So it's interesting. A lot of times when people think of delirium or someone being delirious, they'll think of someone kind of in what they might call a crazed state, acting wildly, agitated is the word that comes to mind a lot. And really that just describes one subtype of delirium. In general, delirium is categorized into motor subtypes, so based upon motor behavior. And that type of agitated delirium is what's called hyperactive delirium. In most cases, hyperactive delirium is actually the minority of cases of delirium. Most types of delirium, or most cases of delirium present with either a hypoactive subtype presentation or mixed subtype. Just like hyperactive is really agitated, and to those of us in the field of mental health might in some ways resemble mania, hypoactive subtype might resemble depression. The person's more withdrawn, subdued, slower in thinking, slower to respond. A lot of times that's missed by medical professionals. They think the person is just tired, or that gets mistaken as dementia, and that's not necessarily the case. The mixed subtype, that definition varies based upon article or studies. DSM-5 defines it as either rapidly alternating between hyper or hypoactive delirium or no motor abnormalities.
That's very important and very interesting, and I think will be news to a lot of people. I mean, many people, not necessarily in the field of medicine, but in general, have an image of delirious or delirium from the TV show where ER, the emergency room, where the out-of-control, thrashing around patient comes in who's completely disoriented and combative or something like that. And that certainly would be one form. But the other form is really important to identify because you got to know what to do.
Absolutely. And some studies actually show that the hypoactive subtype of delirium is associated with worse outcomes. Now, it's unclear if that's because it tends to be missed more or if it actually, in and of itself, confers a worse type of delirium. But there are some studies and in some populations increased risk of mortality actually with hypoactive delirium.
Right. Well, we never have enough time on these discussions, and we're going to run out shortly, but maybe one last really big overview question. Delirium has many, many causes. And I'm just thinking as a starting place that some would be external, like substance-induced or a toxic reaction, or a deliberate sort of drug use, delirious state. Others could be secondary to a major illness. Others could be post-operative, and the list goes on. I guess I'm asking, is that right? Is that how you think about it? And do you think about sort of in your mind a checklist of sort of starting decision tree major categories of cause? Of
causes? I certainly do. In general, the most common cause of delirium is multifactorial. A lot of times, that's, I would say, one of the things that makes it more difficult to actually find a cause is because it's a lot of little causes all as one. There's not one obvious entity that you can point your finger at. The most common single cause of delirium is related to medications, either polypharmacy or medication side effect. That includes usually benzodiazepines or anticholinergic medications, in particular in the older population.
Interesting.
And really when I think about causes, etiologies of delirium, I take a step back and I actually risk stratify the patient in my mind. Someone who has a relatively healthy brain, so say someone who's younger and healthier, requires a much more noxious insult or something really terrible happening to them to become delirious. So that person might have to get to the point of being, in sepsis, septic shock, multiple system organ failure, in the ICU intubated to become delirious. Whereas an older person who has dementia and already has a brain that isn't healthy, let's say, already has some injury that's been done to it, they're much more vulnerable to delirium. And so the etiologies in that case might be a urinary tract infection, might be a medication change, it might be a change in environment and stopping a medication. The etiologies are a bit different depending on the vulnerability of the individual who has delirium.
Well, but that's very helpful. That's a very helpful way to sort of start out thinking, okay, who is this person? And that might help me start thinking about the most likely source of the problem.
Absolutely.
Well, we're going to learn, I hope, a whole lot more. I know we will when you make your presentation in October. But really appreciate your coming by, and even especially because you're still here, and giving us this little preview of the coming attraction. So thanks very much.
Thank you for the opportunity.
Good. And thank you all for joining us once again, and we'll see you next time.